So now we are going to discuss how diabetic macular edema develops. Now we know that diabetic macular edema can be diffuse or it can be focal or localized. This diffuse edema is caused by extensive capillary leakage, whereas this localized edema is caused by focal leakage from microaneurysms and also by dilated capillaries. Now we'll draw the fovea with the normal retinal layers and we'll discuss where does the diabetic macular edema actually develops and how it progresses and how it increases in size and becomes bigger, and the different changes and in shape and the size of the fovea which we encounter during this process. So the first layer is the ILM, the second is the NFL, the GCL. I'll tell you the full forms. In the first ILM, inner internal limiting membrane. Next is the nerve fiber layer, then the ganglion cell layer, inner plexiform, inner nuclear, and outer plexiform layers. Now, when this diabetic macular edema develops, it normally develops in the outer plexiform layer, and between the and the inner nuclear layer, the layer in between. Then in later stages, when it increases in size, it gets to involve the inner nuclear layer, inner plexiform layer, and also the ganglion cell layers and the nerve fiber layers. Okay. Now, so this is the way that it develops. Now, when it increases in size, this all the walls and all the margins of the cyst kind of merge together, and they form a large cystoid space. This so it becomes a large cystoid space in which below the macula, sometimes not below the macula, below the fovea. Sometimes the fovea, which where it develops, loses its contour and gets elevated. So there is an increase in the central foveal thickness. The same finding we can actually find in the OCT also, where every layers we can identify and the larger cystoid space can be identified. In FFA, this large cystoid space gives a flower petal type appearance. This pattern is usually found in the late hyperfluorescence. As we have just told you, it's same finding